This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hey,
We're
Dan. We're on. I'm stealthy recording, not in my normal uniform today. Dan was like, "What? That's your
I can't
podcast
even
outfit?" the shirt I wear every single day.
It's supposedly what you're in now is pajamas. I can't tell.
Inside pajamas. Yeah. No, I thought I'd bring the guns to work today.
Oh yeah, the guns
I'll leave
are
them,
out.
You know, I can. Yeah, I won't. No pit sweat this way. But aside from that, yeah, post surgery, I can break the dress code for a day.
Sure.
Dan's in his usuals.
Yeah, just staying on brand.
Always be branding, as they say.
Which is really just maximum lazy. So
it's minimalist.
It's minimalist. Black polo. Yeah, that's not really a bland, Dr. Blades.
It's consistent and steady.
All right, so this week I have been mucking around with the concepts.
Dan's been in the rabbit hole.
Yeah, I went down like my ADHD rabbit hole. So last week.
So what had happened was.
Wow.
Well, yeah, what's the origin story of this?
Yeah. So I'm in bed and my wife is on her phone next to me and she sends me this article. And it's this article that's once again attacking spinal cord stimulation. And that comes from the group I've now labeled the Australian Anti-Interventional Academic Cartel, the AAAC.
I was gonna say.
Oh my God. Anyway, so they're a group that continuously publishes articles in, relatively poor, low grade.
Poor but public journals.
Yeah, journals. Yeah. And they have a journalist on the team that's in one of Australia's major news agencies. And so as soon as they publish it, it comes out the next day in the paper. Boom. Right. And so they get what they're trying to achieve, which is some negative media around spinal cord stimulation. What then happens is that, internationally, and this has happened every time, internationally, people then write, They publish things in the literature refuting their papers, but it
doesn't matter.
But it doesn't matter. Like there's not like zero news agency is going to pick up that like a bunch of doctors disagree with a bunch of other doctors. Which
is how press and media works. So once you get your point out there, it doesn't even matter if it's refuted. The point got made, and now it's
yeah. So this article's a little bit different though, in that it started off with this crazy sci-fi horrors, like describing spinal cord stimulation as tendrils running up the back of your spinal cord.
With like visceral adjectives and
a sarcophagus put in under your skin. I was like, oh, geez, dude, seriously, we're starting to reach now. But the thing they finished off with was an ad, which I hadn't seen them finish with an ad before, for a thing called cognitive functional therapy. And they're like, it is the best way to get better, and you can do it for $1,000. I'm like, wow, that sounds great.
Well, then when Dan flicked me this too, I was like, cognitive functional therapy, because I sit in that world a little bit more, and I was like, that does not ring a bell, and it's because it's not.
So I got on the PubMed. So PubMed is essentially where, for those like all the patients, so PubMed is basically where you can look at all the scientific and medical literature, sort of where everything gets listed effectively. Right. And a lot of the time, like you can get free copies of everything. And so I get on the PubMed and I plug in cognitive functional therapy, and normally you'll get something like you go, oh yeah, here it is. You'll get one or two articles at least. Zero. And I was like, that is that's odd. Normally would you not I was like, okay, maybe this is just a crappy.
It's just really new. It's really new.
Yeah. But the really new stuff is not the best. So I thought, okay, so this sounds like this article sounds like lying pretty much, and which led me into thinking more about current politics and how lying's just kind of what everyone does.
It is what it is.
No one cares, and no one cares.
Right, because now it's become so pervasive that you just accept it as part of the system.
Yeah. I'm starting to feel like this is lying, which led me to politics. And then, of course, no one cares about lying within politics at the moment. And
what
it led me to this. Trust me, I'm lying.
This is on Dan's recommended list.
Is holding up a book called Trust Me, I'm Lying by Ryan Holiday. If you I love that book. If you want to come to understand how the media works,
how this happens and
how
why
it's manipulated, oh my God, read that book by Ryan. Ryan's gone off to do a whole stack of philosophical stuff
supplementary
these days,
reading. Supplementary reading.
But that was, I think, it was either his first book, maybe it was his second, but I'm pretty sure it's close to his first. And it's an amazing explanation of the media, like absolutely amazing. So anyway.
Yeah, 2012.
Yeah, go Ryan. Great book. So then I started to think, okay, all right, left wing, right wing, centrist. Right. What do those mean, and how could I then maybe apply that to pain? And so just the way I think about left wing and right wing politics. So basically, I see right wing politics is it places the responsibility, the ownership, and everything on the individual. So that is your responsibility to get yourself out of a hole, and it's your responsibility to get on with everything.
You need healthcare, pay for it.
You need healthcare, pay for it.
Pull yourself up by your bootstraps.
Yeah. And what's more, it says that if you're in a particular circumstance, that is your fault. So from a right-wing perspective, it's kind of the way I perceive it. Someone will probably correct me, but anyway, that's the way I say it. On the left-wing side of things, it's where you have, well, actually, this person is in this situation because of societal structures, because of the way we run our societies, because of where they were born into within a class structure. And so
it's not just individual plight.
It's not just an individual decision to end up in that situation, but there are external factors that are overwhelmingly more powerful than the decisions of the individual. And of course, the centrist position sits in between. And the way I sort of think about that is, yes, society does affect where you end up and,
certainly influences
what happens for you. But you're the one that's got to take ownership on getting yourself out or taking advantage of the things that you get offered as part of that. You can come in at the top of society and take no advantage of of what you have access to.
Or have access,
And then you get nowhere, or you end up somewhere worse. So that sort of becomes the three main splits. Everyone can argue about it if you want to say that we're wrong, but it's kind of generally about right. So start to think about pain medicine is kind of the same.
Kind of the same.
And I went through the process of, if you look at pain medicine as a whole, and you think more of it within this left wing, right wing, and centrist, how would a left wing practitioner or a left wing clinician describe and explain pain? How do they see pain? How do they practice?
Yeah. How do you treat them?
How do you treat them?
Based on that. Yeah.
And then what is the right wing? What are they doing? What is the centrist? So here we go. This is like Dan's left wing, right wing, and centrist.
Dan's pain politics. Yeah. That's it.
So left wing politics I see as how do they explain pain? So they explain pain as a false alarm, and they see particularly chronic pain as useless. Like it's not it's
no purpose.
No purpose whatsoever. Yeah. And commonly they describe it as a misinterpretation of a signal. There's no cause for the underlying pain, and you can't diagnose it. So then imaging within that setting is seen as not being useful and makes the patient worse.
Right.
The pain's then driven by psych-related stuff, social status, and it's perpetuated by pain behavior.
And this is the piece where it's more blaming of the patient, or it's the patient's fault, even if it's not their doing, right? It's these socioeconomic, psychological, other things that are...
No, it's a society that's driving it. It's external factors that are driving it, not internal factors, which is a flat cause.
Well, it's in your headpiece. That's what I mean. I don't mean
in your headpiece.
Right. That's which is the patient's fault. Right?
Yeah. Left-wing treatment tends to be more about graduated loading and changing the way you think about your pain. Yeah. It focuses on coping strategies, cognitive behavioral therapy, pain neuroscience, exercise. They don't use, they avoid imaging, they avoid medications. Neuromodulation and spinal cord stimulation doesn't work with this group, which is, where the AAAC comes from.
Right.
And also interventions don't work. And so they are like, none of this works. It's pretty much...
This stuff works. Well, and you're positioning this stuff as that doesn't work because your argument is to pivot more towards the things that then treat the more traditional biopsychosocial sort of emphasis.
Yeah. So right-wing pain. Right-wing pain is like
other extreme.
Yeah, well, right-wing approach, they explain things as pain means damage. So it's not pain as a false alarm, pain means damage. But they end up in the same position. So if you can't find the cause, well, that's because the patient's crazy and it's all in their head. That's pretty much the way it works out. From a management perspective, they will use diagnostic blocks, intervention. From an imaging perspective, if you can't see it on a scan, I can't treat it. That's pretty much the way they think. They use surgery. Spinal cord stimulation is used for when surgery doesn't work. And psych, meditation, cognitive behavioral therapy, pain neuroscience, that's all a waste of time.
That's the stuff that's poo-pooed.
Yeah. And medications are dominantly opioids in that setting. So there's not really a mix of anything else. It's really just dominantly opioids.
Right.
The centrist pain perception is more pain is a warning system. So I like thinking about it from the perspective of it's a system that is asking you to go and have a look, basically.
Yeah, to investigate, it's asking for change.
Now, I got that off one of my psychology friends. Shout out to Dave Young, who we were talking about that. And I really love that concept as pain is a warning signal that's asking you to go and have a look. And
not ignore.
He said he thinks he didn't come up with it, but I don't know who did. So I'm going to discredit it to Dave.
Yeah, but I mean, and however you exactly phrase it, right? That's what Dan and I on this whole podcast have kind of explain in different ways, is to look at it as not just a useless misinterpretation of a signal, but as something useful.
Yeah. So there's likely the centrist sees it that there's likely an underlying cause. We may be able to diagnose it, we may not. We may be able to treat it, we may not. The pain signal is sensitized by changes in both your peripheral and central nervous system, and those sensitizers are broad. They are psychosocial status plays an important role, but so do metabolic abnormalities and untreated or incompletely treated, injury or disease. So so all those things play a role in sensitizing and driving the pain system. The centrist pain management, sits in between. So for those patients that it's appropriate, they'll use intervention, like diagnostic blocks and interventions. For those that are more sensitized, they'll go down the track of, broad-based CBT, pain neuroscience, addressing metabolic factors. Imaging is generally seen as it may or may not be of use, and it may direct us. It's useful to direct us in it, but it's not necessarily going to be exactly what's the cause.
And it can still be useful even if it's not tissue damage or something you have. And it's still, some way of communicating. Yeah.
Medications are used to target underlying mechanisms of action. So the use of medications will be broader. So there's generally limited opioids, but there'll be more anti-neuropathic medications, anti-inflammatories, and different mechanisms, and using different medications with different mechanisms of action. And spinal cord stimulation is definitely an option, but it's used as indicated. It's not used for everything, and it's used appropriately in that setting. Yeah. So that's sort of how I'd split those up. I want to get onto a chat next about how I think that worked out, but I want to step back to one thing, which kind of identifies the split, which is the use of imaging. And so the use of imaging is really, really interesting. And so we got those three camps where what you have is if I can't see it on a scan, I can't treat it. Please get out.
There's nothing there.
There's the opposite end of the spectrum, which is don't get a scan. It'll make you worse. And there's the bit in the middle that says, well, actually, maybe it'll be helpful. Maybe it won't be helpful.
Maybe it may not. Yeah, it depends.
It's got to match you clinically. And so each one of those scenarios are 100% correct. Okay. But depending on which one you use when you're dealing with the patient, depends on a number of things. Number one, it depends on what your skill base is. Now, if you're a surgeon and what you have is the ability to do spinal surgeons, do microdiscectomies, et cetera, laminectomies. If you look at the scan on somebody and they have pristine discs and nothing has changed, there's nothing for you to do.
Your skill set has
that is the end. And so in that setting, that right-wing sort of analogy of if I can't see it on a scan, I can't treat it is 100% correct. Absolutely. Right. And so now the other end is that patient that if you do a scan and you find something, it makes them worse. It drives their anxiety. They become more focused,
more hypervigilant.
This is there. That increases their vigilance. Absolutely. And you know what? It absolutely makes them worse.
Can.
And so for that patient, you do want to avoid the scan. Now,
it's not the perspective that's right or wrong. It's the patient you're applying it to as far as having the best outcome.
Exactly. And so when I'm with a patient, I will do different things, right? So I always look at my scan. So that's rule number 2 of my practicing management.
Right after don't kill anyone.
Yeah. Rule number 1 is don't kill the patient. Rule number 2 is always read your scans. So I always read my scans. And depending on the patient, and depending on where they are within like their thought process, I will do a couple of different things. So if I have a patient that says to me, I think that this is my discs because someone told me I had some whatever. I'm looking at this patient and I am like positive this is a sacroiliac joint. I will show them the scan. I'll say, hey, let's have a look at this. Those discs are perfect, particularly if they are perfect. Like if they have perfect discs and they think it's a disc, I'm going to show them, look, this disc here is perfect and they are all the same. These are pristine. This is not a disc problem. Yes, you have this, but that doesn't, like that imaging finding doesn't correlate with pain. It's just a finding on scan.
Well, and in that setting, you're giving them peace of mind rather than amplifying anxiety.
Yes. I, on the other hand, might have a set of patients that I've already picked up are highly anxious, like they're highly sensitized, that they are focused on lots of stuff. And I look at their scan and they've got a bunch of different things on it that, you know, they've got a bit of facet joint stuff, they've got a bit of disc stuff, they've got a bit of like sacroiliac joint. So all of a sudden, like there's multiple problems. None of them are like from a scan perspective are particularly useful with say, yes, it's definitely, you know, inverted commas, it's definitely me.
Right.
And so I don't show them the scan.
Yeah.
I'm not going to then reinforce that thing. I'm going to direct them. I'm going to guide them in a direction to say, okay, this is how we're going to manage this differently. And I won't use the scan as a primary indicator of how we're going to then go into manage something. And then in the middle, like all the time, like just because something's on a scan doesn't mean it hurts. Okay. So what it's got to do is it's got to match the patient in front of you. So it's got to match their pain diagram. It's got to match their history. It's got to match their examination. And if it doesn't match those things, well, then
it's not relevant.
Like it's not that it's not relevant. It's just not as helpful. Like when all the planets are aligned and, you know, history, examination and your imaging all match up. Oh, fantastic. Bang, bang, bang. Like bang, bang, bang. Like we're on a massive winner. But that's so rarely the case. That's when you have to do some more education within that. And you have to be able to go, okay, yes, you do have this thing on scan, which is what your radiologist has talked about. However, this problem presents like this. So, for example, yes, you've got some facet joint arthritis on your scan. However, when I push on your back over your facets, when you bend backwards and when I jam them up, which is called a quadrant test, it doesn't hurt. That test, when it's negative, means that it's a 5% chance that it's facet joint pain. And so, yes, I get it, but no, it doesn't. You know, your scans don't match it. So we're going to go down. It's not a big
driver of your output of pain.
Yeah. So then I think it's more likely this. If it's not, we'll go then and we'll come back to that. But
and what's key in this is adapting what you do to the patient.
Yeah.
You know, and how you explain it being individualized, where it takes those pre-existing factors into account so you can still use the information, but do so in the most helpful way while minimizing the harm.
And so out of this, I started to think more about this is actually quite a useful way for how you then think about what the patient needs, or more the point, who the patient needs. And so I then started to think about, okay, what's a left-wing pain pattern? Okay, so a left-wing pain pattern for me is pain that's widespread, it's disproportionate. The patient has a high level of central sensitization, and they dominantly have psychosocial stresses. That is left-wing pain.
A big part of their picture.
Yeah. Right-wing pain patterns are focal, proportionate, it's body parts, nociceptive pain. They have low levels of sensitization, and they have little to no background psychosocial stresses or metabolic stresses. And so that's like, that is a very white ring thing. And I think every pain doc goes, yeah, I want to treat more of those, because
I was going to say, that's right. That's
we all want to
ideally where
treat those.
The stab and jab and blocks and procedures work better on more narrow, not necessarily less painful, but yes, easier to pinpoint and diagnose.
And patients. So the centrist pain pattern is, it's either focal or it's widespread.
It's
proportionate or it's disproportionate. And they have moderate to extreme sensitization, which is driven by psychosocial stresses, metabolic abnormalities, and undiagnosed or untreated injury or disease. And so
deconditioning and
so it's sort of like that. That's where a lot of patients sit. So then when you then start applying things, so I just started thinking, where do I sit? Well, I'm center right. Okay. Like, I'm an interventionalist. But my background is sports and exercise medicine. And I see pain as that it's a warning system that is asking you to go have a look, basically. And I think that pain is, it's a warning system that will pick up physical, emotional, social, and metabolic abnormalities. And so it's there, like, the signal's there to protect us.
Right. It is protective. That's not.
It's
totally
there
wrong.
to protect us.
Yeah.
But it's we. But this is. But we, or you, as the experiencer of the pain, you have to take ownership to go and look.
The acting.
Yes.
Do something.
You have to act. Yeah. If you don't act on it, then and you leave it for other people to work out, it never works out.
Right. So, which is why, the own your care pyramid and these different ways of, as a patient, taking more leadership and ownership over your pain is crucial, because you could see, like, we all have different skill sets and interests and biases and training. And so as adaptable as even Dan can be in that scan example with how he tailors, his perspective and the communication around that, a clinician isn't going to completely change their skill base patient to patient. I'm not going to suddenly go do interventions. Dan could go do rehab fitness stuff, but he's, at this part of his career. And so it's more so than matching that up with the patient who presents, in the camps Dan just explained too.
Yeah, and I think that's important. So applying a left-wing management approach to a right-wing patient, a patient that has got focal, not proportionate, even though prolonged pain with minimal, left-wing approach to right-wing pain doesn't work. If you put And the other thing, the other way around, if you apply a right-wing approach, so you start stabbing, jabbing, surgery to a patient with a left-wing pain pattern,
you're not getting very far. You made it worse, most likely.
And you probably made it worse. And so, and then what happens is that because those patients fail, they then go see the other doctors. And so they finally find a doctor that is they then find a left-wing doctor for their left-wing pain, and the left-wing doctors then just say all the right-wing guys are incompetent.
My way works, which is not wrong, but it was a good match.
And then the same thing happens in the other direction. So the patient with right-wing pain that has started with the left-wing doctor, and they've meditated and pain neuroscience and done all that stuff and not got any better, and they go see the right-wing guy. The right-wing guy just goes, "Oh, those guys just don't know what they're doing." And so we have this perpetual accusation of incompetence. That doesn't help, and patients sort of caught in between. So I've this week I found that I've had this lifting of cognitive dissonance.
Dan has had a weight lifted, because we have been, honestly, since we first got together, this was that divide where it's interventionists versus rehab people versus interventionists, and it's this clashing instead of where do I sit on the spectrum? Why?
And how do you explain it? And I think everybody has good intentions.
Sense. Everybody,
so there's a whole thing about this. So everybody has good intentions when they're managing patients. Everybody has successes, which you see, and you see them again and because they come back to see you and they go, "Hey, this is sore again. Can you please fix it?" And you go, "Great, we'll do it." And then you've got, but we're also biased by our failures, because our failures never come back. And so what ends up taking place is that you are consistently seeing, you're getting positive feedback, but you never see the negative feedback, because the negative feedback just goes,
walked out
"That
the door
person's
and kept
an
going.
idiot. I'm never going back." And so you get very biased by your success and the lack of knowledge of your understand of your failures. And like for me, I've always been able to see that there's a group of patients that get better in every group. Like I think there is a bunch of patients that have, back surgery for back pain and they have a fusion and they do really well. And I never see those patients. I only see the ones that haven't done well. And there is a ton of patients out there that go and do a pain program, or they do a pain neuroscience thing, or they do all that sort of stuff. And they do really, really well.
Right.
But I never see those patients because they got better. I just see the ones that failed.
That didn't, and it wasn't enough. Yeah.
That it wasn't. And because I'm like, I'm at the bottom of the therapeutic tree. Like everybody sees everybody else, and then it's like, I don't know, go see your dad. Yeah. So I'm like, I'm biased by everybody else's failures. And so, which is essentially the way we are. Like we're biased by everybody else's failures, and I'm
the same. Oh my God, these rehab people. Oh my God, what do they have them doing in PT? Jesus, they did what intervention on you when you're highly sensitized? So same.
We're all biased by others' failures and our own successes.
And our success.
Yeah. So, but none of it is there's wrong. No bad intention. And I think that what we need to start, for me, I can now verbalize it quickly. That's okay. Left-wing doctor, left-wing patient, really well. Left-wing doctor, right-wing patient, that's the wrong treatment for you. Right. Like that stuff doesn't work. We need to look at this. And vice versa. You had an operation and you've got, and your central sensitization inventory is 85. Yeah, sure. That is why you blew up an enormous ball of pain afterwards.
Makes sense. Yeah.
Wrong treatment. So
or even right treatment, wrong time. Like
wrong treatment, right treatment, wrong time. Whatever. Right at that time, wrong treatment. That is the piece. Like all of a sudden, I have a language that I feel I can describe it relatively quickly, rather than taking how long we've been going for 30 minutes to actually be able to get through and explain it. So now I've got it down.
But this is how sensitization was when we were first breaking it apart. It was like, and then, that makes sense. You can kind of breathe easy because it's real simplified. So all of these terms, like all of these treatments, all these types of pain, all these presentations, what we've talked about throughout these myriad of episodes, you as a listener too can see, it does just sit on a spectrum. And the clinician is sitting on that spectrum. And I, as a patient, should also start critically thinking about who should I seek out? What type, am I left wing? Am I right wing? Or what type of doctor do I need? Because the doctor can only offer you his skill set. Ideally a referral if his skill set doesn't match your presentation, but if they can't recognize it, you have to. So that too comes back to, what type of doctor can I work best with? Can I collaborate best with?
Yeah. And that's
so it's very useful.
Yeah. And that's the right wing perspective of you've got to own it. So
own it, but get the right help. Yeah.
I'm center right. Juz, where are you?
Center left.
Center left.
Center left. Yeah.
So there we go. All right. For fun, if we can find any comments tell us where you are. Tell us what you think you've got. Have you got left wing pain? Have you got right wing pain? You got centrist pain? Yeah. Have you got what sort of clinician are you? Throw it in.
Exactly. Yeah.
It's good for it. It's an interesting thought process. And yes, it's oversimplification, but it works. Well, I think it works. We think it works.
No, it cuts through some of the different reasons that you have mismatches and poor outcomes and different expectations and bad experiences. And if we can negate some of that by looking at it more effectively, that's helpful.
Yeah.
And it also removes some of the blame and shame and the infighting, right? Because that's not helpful for anyone either. Also, patients at clinicians, clinicians at patients, different clinician camps at each other. It's going to all work a little better together, ideally. Is that too much to ask? Cues to America's political landscape. We hope this takes better than democracy has in our country lately. But, so.
Oh, well. We'll see how we go.
Good work on that, though, Dan. I think this is a great way to look at stuff. And hopefully it's helpful for you, too.
Okay.
All right. Cool. See you, Dan. Bye, guys. See you next time. This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers.